Now we will be with the second lecture of Professor Randa. Professor Randa Badawi is a professor of anesthesia faculty of medicine in Cairo University and Saudi Arabia as well. She is devoted for hard work and professor of anesthesia, 30 years experience in Qasr Ain Hospital. Dr. Randa also is a teaching professor at the Faculty of Applied Medical Science in Imam Abdurrahman University in Jubail, KSA, Saudi Arabia. She has a special interest in airway management and fiber optic, and she's an instructor in airway management program in Qasr Al-Aini. She's also an instructor in European Restoration Council for PLS, ALS, and APLS HCC. Dr. Randa, she's keen on attending sessions and courses and temporary Jamal, and is also attending medical education course. Dr. Randa also, she's an examiner of anesthesia fellowship and emergency medicine fellowship. We expect by attending Dr. Randa lecture on anaphylaxis, all of our colleagues should understand and diagnose what is anaphylaxis, what is anaphylactic reaction, what is the most drugs that may be associated with intraoperative anaphylaxis, what is serum tryptase, how to prevent and how to treat anaphylaxis. Please, Dr. Randa, can you go?
Good evening, everybody. Thank you, Dr. Adel, for the very warm introduction. Today, I'm going to discuss anaphylaxis. I'm going to cover the following items: anaphylaxis meaning, causes precipitating anaphylaxis, risk factors, how to treat this situation. Anaphylaxis is an exaggerated response and life-threatening condition manifested by generalized or systemic hypersensitivity reaction, mostly due to antibiotics. It's mediated by hypersensitivity due to release of the IgE antibody. It occurs within minutes of exposure to a specific antigen. It's characterized by life-threatening, rapidly progressing deterioration in airway, breathing, and circulation, may be associated with skin manifestation or mucous membrane. This is the least important, but it clinically may be so prominent, but it, as regards clinical importance, is not that significant. That can occur rapidly from irreversible or respiratory or circulatory shock. The incidence of anaphylaxis during anesthesia has been estimated to be 1 every 500,000 or 1 to 20,000. The most common factors incriminated in the occurrence of anaphylaxis under anesthesia is the neuromuscular blockers, antibiotics, also non-steroidal anti-inflammatory aspirin are very common. Latex is also important factor. How to diagnose? Certain criteria should be fulfilled. Unexplained hypotension, unexplained bronchospasm, unexplained tachycardia or even bradycardia, angioedema. By angioedema, the skin manifestation characterized by redness, erythema. This is at the level of skin. This is due to capillary leakage, which is part of the pathology of the situation, which is related to the histamine release, which leads to vasodilatation and increased capillary permeability. So at the level of skin, this causes the erythema and urticaria reaction. When this capillary leakage goes into the deeper tissues, this is called angioedema. Example, edema of the eyelids, edema of the tongue, and this is very serious sign. Whenever you find a face involvement, this is a really life-threatening condition, and it may indicate an impending death if not properly managed. So angioedema, not always it occurs, but if it occurs, it's a very serious complication. We should take it a good observation to pick it early. Maybe unexplained, the patient presents with sudden cardiac arrest, where the causes is not unknown. Cutaneous manifestation is the least important. As regards the pathophysiology, it's an autoimmune disease of the IgE type. Here, there is a release of inflammatory mediators from the mast cells and basophils triggered by an allergen. This leads to interaction with cell-bound immunoglobulins of the IgE category. However, it might be a non-IgE or non-immune release also, but this is rare. The majority is based on autoimmune. This leads to release of mediators, histamine and leukotrienes. Histamine leads to vasodilatation and increase in the capillary permeability, leading to edema and decreased venous return. As we said, trigger factors, it might be in general food, this especially in children, or in adults. It's mainly related to drugs or sting bites. The presentation differs. It's very rapid. It occurs within 30 to 35 minutes after food administration. It can occur following 10 to 15 minutes in case of insect bite. The worst scenario is with drugs, as the reaction is can occur within 5 minutes, and this may lead to serious complication. Whenever we face a case of anaphylaxis, how to manage? Number one, we should call for help. The manifestation arises suddenly. The patient presents with multi-system affection. More than 2 systems are going to be affected, mainly cardiovascular in the form of hypotension, tachycardia, maybe ECG manifestation of ischemia due to the low blood pressure, even in a normal person, not a cardiac one. The patient may present with bronchospasm and increased airway pressure, manifestation of wheezes. If the patient wasn't under GIT symptoms may occur in the form of diarrhea or nausea or vomiting. So it's multi-system affection, skin manifestation, we said it before. So whenever we diagnose, we have to start immediately without any delay to manage. Number one, and the most important, is to call for help. Whenever you face any kind of problem, you have to call for help. And not the team. If you are under GA or in the OR under anesthesia, you have to stop any factor which might be the triggering agent. If the surgery wasn't started, it's advisable to cancel it if it's possible. It's advisable not to start the surgery. Then start to resuscitate the patient and let the CPR trolley stand by, because cardiac arrest is quite common in this situation if not properly managed. You have to remove all the potential causes if it's possible. If you are giving a colloid solution, stop it. If you are putting an antibiotic infusion, withdraw it. If anything is going on, you have to stop it. If you give a bolus drug, it's no way to withdraw it. Intravenous colloids should be considered as a triggering agent during anesthesia. So you have to take care. If you are running a colloid, you should withdraw it. You should shift if under GA and you cannot postpone the surgery. You should shift to the inhalational anesthetic agent better than the IV, because the IV may be incriminated. So although it's not common, but it's better to use the inhalational as they are not incriminated in this situation. To start management, this is a critical ill patient. So we are going to follow the ABCDE approach. Number one, whenever you are resuscitating a critical ill patient, you should administer 100% oxygen. This is in the very first beginning. Then we have to secure the airway as regards A. This is a life-threatening condition, especially if you find a clinical sign suggesting an airway involvement. If the patient is under regional, you can pick it from his voice. If there is hoarseness of voice, this means that the larynx is involved. But if the patient is not awake, you may find another symptom. So if the patient was not intubated, maybe you give in the preoperative antibiotic and he developed the anaphylaxis. In this situation, we are going to manage, and accordingly, we might postpone the surgery at all, but we have to save the life of the patient. I have to secure the airway. How to secure the airway? Definitely by endotracheal tube, because supraglottic device has no role in this situation. It will be difficult to insert. Then when the situation deteriorates, you cannot ventilate through the supraglottic device properly because they develop bronchospasm in addition, which is a contraindication for the use of supraglottic devices. This is as regards the A, secure the airway with endotracheal tube. The trick is too early. This is the most important issue, because if you wait, it will be more difficult and the situation will be very difficult. So you have to secure early, especially when there are signs suggesting of the anaphylaxis, especially if angioedema is eminent, if the eye are swollen or the lips, or there is hoarseness, or the manifestation of multi-system affection, meaning that anaphylaxis is going on, I have to secure the airway early under any condition. It's better to call for an expert anesthetist to intubate such patient, and he should be ready with the difficult airway chart. This is as regards the A. As regards the B, we have to check the breathing of the patient by the look, listen, and feel. Look for if he was spontaneously breathing or he wasn't under anesthesia yet. You have to check his rate. You have to expose his chest to see bilateral chest rise, the rate. You have to look at the monitor as regards his SpO2 and tidal CO2, then manage accordingly. Auscultate, look, listen. You have to auscultate. You may feel wide scattered wheezes. However, if you didn't hear any wheezes, this is not a good sign. A silent chest is an eminent sign of indicating severe bronchospasm. And then check the blood pressure of the patient. If the patient is hypotensive, also if the patient is intubated, look at the airway pressure. You will find it elevated. You can find on the capnogram signs of airway obstruction, which is denoted by sloping upward curve of the capnography. This is as regards inspection, look, listen, and feel, or what's called inspection, palpation, percussion, auscultation. That we have to shift to C. We have to check for the blood pressure of the patient. Definitely, if it's decreasing, this is very serious. This is the most feared complication, respiratory and circulatory, as they may lead to cardiac arrest for the respiratory or circulatory reason. In this situation, if the blood pressure is below 50, cardiac arrest mainly is coming. You can manage simply by elevating the legs of the patient to increase the venous return. And if the blood pressure is below 50, you have to start immediately CPR in this patient. Then we have to start drug medications. For the hypotension, the pathophysiology is related to vasodilatation. So the patient became relatively hypovolemic. So number one, I have to give plenty of fluids. So we give fluid bolus of 20 ml per kg. This can be normal saline or lactated ringer. Then you should start with adrenaline. The most important and the life-saving drug is adrenaline because it has many beneficial effects. Its alpha effect leads to vasoconstriction, and the pathology is vasodilatation due to histamine release. It decreases histamine release, which is the problem. Then the beta effect, it leads to bronchodilation, so it's very beneficial. The key is to start it early. This is the most important, and to start the adrenaline early to shut down the circle. Its alpha effect will help to reverse the drop of blood pressure as it causes vasoconstriction. The beta effect will improve the bronchospasm, and meanwhile, it will abort further release of histamine. We start by intravenous bolus. Then, if no response, we can repeat it up to 3 times. If the situation is still not responding, we have to shift to another alternative, or you can add adrenaline by infusion. The alternative drugs are vasopressin or noradrenaline, levodopa, I mean. If the patient is on beta blockers or calcium channel blockers, we may add glucagon. Adrenaline is a physiological antidote for this reaction, and we said the reason. We start by intravenous route in a bolus 50 mic IV. If the patient has an IV line, I have to start with the IV line. If the problem occurred but no IV line, I cannot find because he's shocked, shift to the intraosseous route. Provided I'm an efficient one to give in that route. So intravenous route, this is very important. Intravenous or intraosseous, as intraosseous is considered as if it's IV line. You should be expert to use that route, because although adrenaline is a life-saving, but it may put the patient in a further deterioration if you cannot manage its complications. The one who should use IV adrenaline should be an expert one. How to use vasopressors, how to titrate these drugs, and the patient should be monitored. If these criteria are not fulfilled, so you can give safely intramuscular. As regards the intravenous route, it's 50 mic IO or IV. This is how we prepare it, because this is the important. The ampoule of adrenaline of 1 milligram, its concentration is 1 to 1,000. So I have to dilute into 1 to 10,000. This means 1 milligram of adrenaline. I added to 9 milliliter of saline to make the total volume 10 milliliter. So this means that every milliliter contains 100 mic. The dose is 50 mic, so I have to give a bolus of half milliliter each time, then flush and repeated while you are monitoring the hemodynamics, meanwhile having a look on the ECG of the patient. If you exceed 3 boluses, you should shift for the infusion. This is as regards the dose for an adult. For pediatrics, the dose is 1 mic per kg. How we can prepare it? Because this is the most important, the clinical part. In pediatrics, the concentration is 1 to 100,000. So I have to dilute 1 milliliter in up to 10 centimeters. Then I can take 1 milliliter of the diluted that of the adults, 1 to 10,000, and take 1 milliliter and dilute it again into another 9 milliliter. So, and start to give 0.1 milli per kg. This is for the pediatric patients. Also give it by intramuscular or intraosseous. Or to maintain, if he tried 3 times and no response, you have to shift for the continuous infusion. This can be done by diluting 5 milligram of adrenaline on adding it to 500 milliliter dextrose by 5% or normal saline. This means that there is access 0, I'm sorry. 5 milligrams means 5,000 on 500, so the 1 milliliter contains 10 mics. and start infusion and manage titrate according to the readings on the blood pressure. You may alternative drugs, vasopressors, or glucagon in case of the patient is receiving beta blocker or calcium channel blockers. To return again, sorry, for adrenaline, if you are not expert or you are outside the OR, maybe you face a patient with anaphylaxis in the ward or not on the ER and you don't have monitors, so you should stick to giving the adrenaline by the intramuscular route. How to do it? It's given in the thigh, in the upper lateral 1/3 of the thigh. This as regards the adrenaline. Adrenaline should be given by a senior expert one, as it may lead by itself to death if you are not, you don't know how to manage. If you give adrenaline IV to a spontaneously breathing patient, I mean that he is not arrested, it may lead to severe tachycardia, severe hypertension, arrhythmias, ischemic manifestation. So I should know what's going on through the monitor. If I'm not senior enough, it's better to use it by the intramuscular route. NOS, half milligram intramuscular. Other drugs to be used during anaphylaxis, definitely steroids, which are well known to be given in case of allergic reaction. The route is definitely intravenous. According to the age, if it's a child less than 6 months, you can give 25 milligram. If a child is 6 months to 6 years old, double the dose into 50 milligram. If the child is 6 to 12 years, double again the dose, it will be 100 milligram. If the patient is an adult, double again, it will be 200 milligram. This is for the steroids. The other line, which is the second line of treatment, is the antihistaminics. We can use chlorphenamine. The route definitely in a critically collapsed patient, the route is definitely IV. For pediatric, less than 6 months, 250 mic. If the age is 6 months to 6 years, give 2.5 milligram. If the age 6 to 12, double the dose into 5 milligram. If he is adult, double again to 10 milligrams. As you are administering adrenaline, breathing should improve, because in management of asthma, the last resort, we give adrenaline. So if you give the adrenaline by the intravenous route, but there is still bronchospasm, we should manage more aggressively. How to know that the patient has bronchospasm? We said that before, that it will be obvious on the monitor as increase in the airway pressure, and it will be obvious on the capnogram. The patient also on the may show desaturation on the pulse oximeter, and if he develops hypercapnia, this is the worst case scenario you can ever meet in a patient, asthmatic patient. This means that it's an imminent death. This is a life-threatening condition. So if you find an asthmatic patient and who starts to develop hypercarbia, you should intubate this patient. Don't wait, because it's a life-threatening condition. For the management of bronchospasm, first I have to exclude an iatrogenic cause for the increase in the airway pressure, as if the tube is endobronchial. So one of my confirmation is to listen bilateral for air entry, to exclude endobronchial intubation, as it may cause spasm and elevation of the airway pressure. Number two, exclude that the tube is obstructed. These are the reasons why the airway pressure is high. So it may be the tube may be obstructed from outside or inside. From outside, it may be kinked. So be sure that the tube is not kinked, no any obstruction in the circuit. Then you should pass a catheter through the endotracheal tube to exclude obstruction. Here, while we are managing to keep the patient at a good level of anesthesia, we said it's better to use the inhalation rather than the IV. Here, we should avoid isoflurane and this fluorine if we would like to deepen the level when the hemodynamics allows, because they have an irritating airway effect. So they are not the ideal drugs in this situation. And then you have to administer the drugs to treat the bronchospasm. What are the drugs to be used? Definitely beta stimulants is the golden standard. We use salbutamol. It's given by nebulizer. This is the first choice. We give it by a meter dose inhaler or nebulizer. For the nebulizer, it takes about, it will take an action immediately. So we have to repeat it every 15 to 20 minutes if the patient doesn't show any improvement. As regards to the dose, for child less than 5 years, the dose is 2.5 milligram. For an adult or a child more than 5 years, you should use 5 milligram to be repeated, as we said, every 15 to 20 minutes. You can try up to 3 times. Then you should shift to continuous nebulizer use or to the intravenous, as we said with the adrenaline. Try intermittent doses, no response, shift to continuous route. So nebulizer that can be given, should be given with a high flow oxygen, as nebulized drugs will not be delivered to the lung effectively if the patient is hypoventilating. This is if the patient is spontaneously breathing, definitely, or is not under anesthesia at all. This is a common recommendation. If a nebulizer is not available right now or immediately, you can give temporarily emitter dose inhaler via a large volume spacer device. Then, if no response with the nebulized salbutamol, we have to shift to the intravenous route. This is the second line for treatment, second line route, I mean, for the beta stimulant. For children up to 2 years, the dose is 5 mic per kg once over 5 minutes. So I give it slowly and it's once. The maximum dose for a child less than 2 years is 250 mic. If the child is 2 to 17 years old, the dose is 15 mic per kg. It's also given once. So the maximum is also 250 mic. For adults, the dose is the 250 mic, and it should be diluted and given slowly. If this, when we give the drugs by the nebulizer, no response, I can give IV bolus. If no response, now I should start the infusion. The infusion dose is half to 1 mic per kg per minute for a child. For an adult, the dose is 5 to 20 mic per minute. Not per kg. Take care. Okay. Other modalities or other drugs to be used is the ipratropium. This is an anticholinergic drug. It can be given by the nebulization in case the patient is not responding to the beta stimulant. Here the dose for an adult, we give half milligram and repeated 4 to 6 times per hour. For a child 2 to 12 years, the dose is 0.25 milligrams. Adrenaline for cases for bronchial asthma or severe spasm. Here we are covered with the dose given by infusion for the hemodynamics. The doses for in case any bronchospasm. You can start with a dose also start with a nebulizer route, nebulization. Child, you use half milliliter of the original concentrated drug, 1 to 1,000 concentration. For an adult, you use 5 milliliter of the same solution. I mean, not diluted. The original concentration, take it, then add to it the saline to put it in the nebulizer. I mean the dose, half milliliter of 1 to 1,000 or 5 milliliter of 1 to 1,000, then diluted before mixing in the nebulizer. Slow IV dose, this is the dose, 0.1 to 1 mic per kg in children, or 10 to 100 mic for an adult. Another line of treatment for severe persistent bronchospasm is magnesium sulfate. But here, in this situation, magnesium sulfate leads to hypotension. So if your patient is still hypotensive, don't give magnesium sulfate. This is for the general lines for management of bronchial asthma. The guidelines, but you should think what's the risk to benefit ratio. However, if the patient is improving as regards the hemodynamics with the fluids and adrenaline, but there is still bronchospasm, you may add magnesium sulfate. The dose is given by slow IV over 20 minutes as it causes hypotension. The dose is 50 milligrams per kg for pediatrics. For an adult, you give 2 grams. To use, in the last we used to use aminophylline as a first line treatment. Now it became in the late stage in the list because it has a very narrow therapeutic to toxic effect ratio window. So it's not advised to use it early in the management. It should be used only in severe or near fatal asthma. Loading dose is 5 milligrams per kg. It should be given slowly IV over 20 to 30 minutes. You should omit giving a bolus loading dose if the patient is already on thiophelin treatment. Then we give intravenous infusion. For an adult, the dose is 5 milligram per kg per hour. For a child 9 to 16 years old, the dose is 0.8 milligram per kg per hour. Less than 9 years, the dose is 1 milligram per kg per hour. Take care, the dose is increasing with decrease in the age. This as regards the drugs to be managed. How to manage the ventilation? The patient, if we face the problem intraoperatively and the airway pressure is elevating, how to manage? The risk of severe bronchospasm that the patient is not able to get rid of the expired air. So air will be trapped. So this may lead to what's called auto-PEEP, and it may lead to bilateral pneumothorax, which is a very serious complication. So we have to avoid using a large tidal volume in these patients. So the strategy will be to increase expiratory time. Why? To give time for the air to be completely exhaled. Number two, shift to pressure control ventilation may be better, and allow what's called permissive hypercarbia may be appropriate in these patients. As you know, the determining factor to get rid of the CO2 is the tidal volume. And in this situation, I'm obliged to use the minimum allowed tidal volume just to see a good chest rise. So the patient may develop a little bit hypercarbia, but this is much better than develop auto-PEEP and barotrauma pneumothorax, which if it occurs, it might be bilateral. This is the management of the anaphylaxis.
Thank you very much. Randa, thank you very much.
You're welcome. Thank you, sir.
Very comprehensive lecture. And I want to relay the question of our attendees first. Professor Saad, can I unmute you, please?
I'm not, I don't hear you, Dr.
You hear me? You hear me, Dr. Saad?
Yes, I do. Yeah, thank you.
So, Dr. Ahmed, she unmuted. Can you unmute her?
Oh.
I don't know.
Dr. Randa is, she's okay now.
Do you hear me, Dr. Randa?
Yes.
Okay. There's one question here from one of our colleagues. What about the skin test, pre-operative or intraoperative skin test for hypersensitivity, for example, like antibiotics? Is it reliable to do?
Definitely, you know, we are all anesthetists. You don't do a test before. We do tests, skin tests for antibiotics, but we don't use for an example for non-steroidal or for muscle relaxant. We always give the muscle relaxant without skin test. So
yeah,
we, but
for the antibiotics, yeah.
For antibiotics, definitely you should do skin test before, definitely.
Okay. To comment upon this point, we have a debate on our institution when to give the antibiotic, because usually the surgeon wants to give the antibiotic immediately after induction of anesthesia. And our anesthetic maybe have patient allergic like rocuronium or other drugs. So we don't know which one is the reason for the allergy.
No, the proper way for management by the book, antibiotics should be given 30 to 1 hour before skin incision. So it will be this is the correct way, number one. Number two, it will eliminate the debate, which is the incriminated drug. whether the antibiotic or the muscle relaxant. So because in case of drugs, the reactions appears immediately within 15 minutes, 5 minutes also, sorry, for 5 minutes, the intravenous drug effect will appear.
There is one question here about the preparation of adrenaline inhalation.
Yes.
How they prepare that for inhalation and bronchospasm.
In case of, we mentioned, in case I'm going to, we take the adrenaline as it is from the ampoule, 1 milligram, 1 to 1,000. This is the concentration. I take half milligram in case of pediatrics, while for adults, I take 5 ampoules of 1 milligram, then add to it the saline in the nebulizer and start to inhale it. It depends on the dose. The dose is half milligram of the undiluted from the ampoule of the 1 to 1,000 concentration. In case of pediatrics, the dose is half milligram. The dose in adults is 5 milligrams.
Okay. Here again, want to ask about the atopic patient. Is atopic patient at risk of?
Yes, these are the worst patients you can ever meet. The atopic patient, because the patient who is atopic or asthmatic, when they develop anaphylaxis, the mortality rate increases. So I have to be very careful while taking the history in case of asthmatic or atopic patients.
So pre-anesthesia assessment in the clinic is very important, crucial to detect patient at risk of developing anaphylaxis.
Another, I want to add, we have to, for the clinical, as I mentioned, atopic, for the differential diagnosis, anaphylaxis may be mistaken with a case of sepsis or severe asthma. So I have to watch what the patient, or panic attacks or vasovagal. In this situation, if you give adrenaline, you may kill your patient. So I have to diagnose properly. Anaphylaxis means more than 2 systems involved after exposure by a triggering drug, while vasovagal, no triggering agent. So this is a category. If only skin manifestation was evident, this is not an anaphylaxis. Never to give adrenaline in this situation, because adrenaline has a great risk for the patient, as we mentioned. Also, if the presentation is only chest, respiratory, this is not an anaphylaxis also. We manage as a case of severe bronchospasm, as we mentioned, how to manage.
Okay. Is there any rule for post-operative observation as an exit?
Yes, definitely, definitely. If the patient is coming for daycare surgery and he developed severe bronchospasm, or severe anaphylaxis, he should be watched for 24 hours in ICU unit, because there is an incidence of what's called delayed anaphylaxis. If he develops, he might develop. So he should be observed for 24 hours in an ICU unit.
Or biphasic, we call it biphasic sometimes. Biphasic exists from some debate about the terminology.
Also, for the academic purpose, we can, to confirm the diagnosis, you can make certain lab that's tryptase, you measure mediator of the mast cells. We take 3 samples, one at the time of whenever you suspect, but never to delay treatment to take a sample. Start resuscitation, meanwhile take a sample, then after 2 hours, then after 24 hours. That's for documentation purpose. Because abroad, they should document what's going on by solid data, not only the clinical.
Here, I want to stress only we should inform a patient, give him bracelet in his hand, whatever, or that we bring with him every time to go to anesthesia. Very wonderful lecture, Dr. Randa, Dr. Walid, thank you, everyone, and Dr. Saad, this is much good.
Thank you much, Professor Randa and Dr. Walid, Professor Adel, for moderating this session, and excellent chance, and our panelists today, and a lot of professors here supporting us. That's why this course by all of you is supported by the Egyptian Society of Anesthesiology for personal development and for education. That great success. Our course is really very international by you and your support, and we have a mixture of obstetric, general, ICU, and pain management, which is a great chance and opportunity for everybody to study. All our lectures are stored in our mega YouTube site, Mega Academy, Mega Medical Academy YouTube, and anybody can go back to those lectures and review them at ease. I would like to thank you very much, and next Thursday كل سنة وانتم طيبين عيد إن شاء الله, and we'll be off, and the following Sunday will be off as well. So last session for this module is next Sunday, because our first module finished next Sunday. So we'll take 1 week off, and we'll start again the Thursday after. And from myself here, happy Eid, and see you next Sunday, this coming Sunday. And thank you very much, everybody here tonight. Thank you.
Thank you very much.
Thank you, everybody. Thank you for everyone.